Assalamualaikum and selamat tengah hari semua.
Waalaikumsalam, Doktor.
How are you today? Good.
Yes, Doktor.
Very good. Alhamdulillah. So, ada yang duduk dekat dalam kawasan kampus ke? Kawasan dalam fakulti ke? Dekat college? Most of you.
College.
Most of you college lah. So, the line is good there? Not really.
Not really.
Not really. Okay, kalau you all rasa berada dalam kawasan fakulti bagus, the line, dan duduk ada dekat area sini, I think the wifi is okay je. Saya pun guna wifi fakulti juga ni. Okay. Alright, so sorry 201, so I should start. Saya kat fakulti cari line. Okay. Semoga berjaya. Alright. Okay, so I think we should start our lecture today. Boleh nampak tak? Boleh datang. Alright, kalau saya terputus di mana-mana, please stop me somewhere, okay? Okay, so today we're going to proceed to another chapter, which is MNT for hepatobiliary and pancreatic diseases. So for this chapter, there are about 140 slides, okay? But I'm not going to cover everything today. For online class, normally 1 hour. The rest would be your own readings lah. Sebab 2 hours pun saya rasa untuk rasanya dalam pukul 5 dah sebut, kalau untuk online class it should be 1 hour. Okay, so the remaining would be your own effort untuk mencari more information ataupun reading up and everything lah. Lagi pun nak limitkan the use of data for those students yang pakai your own phone data. Alright. Okay. So the learning outcomes of this chapter is that by the end of this lecture, you'll be able to explain the pathophysiology for each of the diseases, demonstrate an appropriate nutritional status assessment and intervention, and last one, to develop the nutrition intervention with appropriate goals and objectives in solving case studies of hepato and pancreatic diseases, right? So this would be the lecture content. Okay, so since you are already in year 3 kan, yes, and 6, so I'm not going to further discuss in details on the anatomy and physiology because you have learned in year 1 and year 2, right? So this would be an overview for you to refresh back what you have learned previously. Okay, so about the liver. Liver is the largest gland in the body, and it has it is divided into 2 lobes, which is the right and the left lobes. So it's about 1.5 liter of blood is circulated through the liver and exit via the hepatic veins into the inferior vena cava. So in this liver, bile is formed and it is exits through a system of ducts. So what would be the function of bile actually? Can any of you answer? Bile juice. Digest fat. Yes, for fat digestion, metabolism of fats lagi. Mainly is actually for fat metabolism lah. Alright, so at the end of this study, at the end of this lecture, you will going that you can see that a lot of problems could happen whenever a person has a liver disease, because their liver is greatly affected, okay, due to viral infections or anything that could happen, and there are many factors actually. All right, so this is the anatomy of a human liver. And for the functions, it is integral to most body functions, and it can perform more than 500 tasks. So fun fact is that you cannot survive without a liver, but only 10 to 20% of function is needed to sustain life. And another one, the liver has the ability to regenerate itself. So other functions like metabolism of major nutrients, activation and storage of vitamins and minerals, especially for the fat-soluble vitamins, formation and excretion of bile, metabolism of steroids, conversion of ammonia to urea, and as a filter and blood chamber. So there are many diseases that are related to liver, like acute viral hepatitis, chronic hepatitis, alcoholic liver disease, non-alcoholic, and cholestatic, and other inherited disorders. So for this chapter, I'm not going to cover every diseases, right? So first, a disease that we are going to look into is hepatitis. So hepatitis itself is referred to inflammation of the liver, and it can be caused by hepatropic viruses, reactions to chemical agents, drugs and toxins, and also autoimmune diseases, and lastly due to infectious agents like Epstein-Barr virus, herpes simplex virus. So these are the causes of hepatitis. Okay, so hepatitis itself is divided into two, acute and also chronic hepatitis. So for acute viral hepatitis, the inflammation is mainly caused by virus A, B, C, D, and E, and they have different ways on how to infect into body. Okay, for example, Hep A and E, it is through oral fecal route. For Hep B and C, through bodily fluids, and for Hep B, which occurs only in patients with hepatitis B. So for the acute viral hepatitis, it is actually a prompt immune response during the acute phase of infection, which could be expected to cause cell injury. But at the same time, it tries itself to eliminate the virus. So people who respond with fewer symptoms and a marginal immune response are less likely to eliminate the virus, and hepatocytes expressing the viral antigens persist, so which then will lead to chronic or carrier state. Okay, fulminant hepatitis, meanwhile, is an accelerated immune response with severe liver necrosis. So these are the clinical manifestations of hepatitis, right? So there are 4 phases. The first is the incubation period, which at this point, there is no specific symptoms may appear. It's just like normal symptoms, for example, loss of appetite, nausea, malaise, and also you might experience pain at the right upper quadrant. And then it will enter to another phase, which is the pre-icteric phase. So at this point also, the symptoms remain non-specific, but about 10 to 20% of the symptoms is due to immune mediated, for example, fever, arthralgia, rash, angioedema. And then it will enter the icteric phase, whereby you can see like prominent symptoms, for example, skin discoloration, which is jaundice, and also discoloration, yellowish color on the sclera of the eyes, weight loss, dysgeusia, and also pruritus. Okay, and the last phase is the convalescent. Convalescent is the phase whereby the liver is trying to eliminate the virus. So at this point, the jaundice and other symptoms may subside. So for hepatitis, you can be the carrier and also you can be the one that are infected. So for the carriers, there are two types of carriers. First one, healthy carriers with minimal or no ill effects, and another one is those with chronic diseases who may present with or without symptoms. And the factors of being a carrier are age at the time of infection and also your immune system. So for those who have impaired immunity, who have received multiple blood transfusions, those who are on hemodialysis, those who are drug addicts, and also infants of HBV infected mothers are actually high risk for becoming carriers. And next is the chronic viral hepatitis. So chronic viral hepatitis is the principal cause of chronic liver diseases if it is not treated, and also cirrhosis and hepatocellular cancer in the world. And now it is ranked as the chief reason for liver transplantation in adults. So chronic Hep B accounts for about 46.1% of chronic liver disease and cirrhosis in Malaysia itself. So the prevalence is higher among Chinese, followed by Malay, and Indian is the least. Okay. And for chronic Hep C infection, which is often often be seen among Malays, and then during a period of years, it is actually silently destroyed the liver cells. So most persons with chronic Hep C are asymptomatic, okay, because of the cause of acute hepatitis C often is mild. Many persons cannot recall when would be their first event of the acute infections. So there are many risk factors for chronic viral hepatitis. For example, drug use, those who are with chronic kidney diseases, who is on hemodialysis, and then blood transfusion or blood transplantation patients, those who receive blood through needle stick from a donor who is a positive of Hep C, and then Asian ancestry, kita lah sebenarnya Hep B, kita more prone to get Hep B, and then unvaccinated healthcare workers, those who have sexual transmitted diseases, those who practice illegal and unhygienic body piercing or tattooing, those who have contacts with Hep C positive persons, and infants who were born from mothers with chronic Hep B or Hep C. Okay, next we proceed to alcoholic liver disease. So this is one of the most common liver disease, and mainly, of course, it is caused by alcohol excess and abuse. So in US, it is the most common cause of liver disease, and it is the fourth leading of death among middle-aged Americans. So alcoholic problems at US are highest among young adults aged 18 to 29. So meanwhile, in Malaysia, it is more common to happen in males and also among Indians. So the risk factors of ALT is, of course, due to their intake of the alcohol, how much they consume, and how long they have been on being alcoholic. And then those who have a problem with alcohol metabolizing enzymes, gender, which male is more prone compared to women, and those who are on drugs, infections with hepatotropic viruses, immunology factors, meaning that those who have low immunity, obesity, and also poor nutritional status. So the spectrum of alcoholic liver disease can go from fatty liver disease, alcoholic hepatitis, and can result to cirrhosis. So this is the toxic effects of excess alcohol use. Okay, so whatever there are many complications happen due to excessive alcohol consumptions, which is largely coming from the excess of hydrogen and also acetaldehyde. So alcohol is actually coming from not coming. It is through metabolism dia akan metabolize into acetaldehyde and also hydrogen. Okay, so this hydrogen will produce fatty liver because it will replace the fat, okay, as a fuel source, and also it will then be accumulated in the blood. So at the end, a fatty liver could happen, and other than that, hyperlipidemia, high blood with lactic acid, and also low blood sugar. Okay, so the accumulation of fat effect of the acetaldehyde on the liver cells could result to alcoholic hepatitis. Okay, so the consequent impairment of this liver function might disturb the blood chemistry, causing high level of ammonia, which resulted to coma and death. Okay, and then the structure of the liver cells also will be deteriorated, okay, will be affected, okay, especially it can resulted it can the structure of the liver cells can turn into necrosis, and at the end will resulted to cirrhosis, which cirrhosis meaning that the hepatocytes will be macam mana nak cakap, bentuk dia akan menjadi seperti like fibrosis. Okay, maksudnya dia punya cells dia cannot function properly. Okay, so because of the structure of the hepatocytes are greatly affected, okay, so it will inhibit the blood flow into the liver. So, and then there will be obstruction of the blood flow, so there will be high pressure in the vessels supplying the liver, which at the end can cause rupture of varices and also accumulation of fluid in the peritoneal cavity, so which is called as ascites. Okay. Next is three clinical conditions of the ALD, which is the first one is hepatic steatosis or the fatty liver. So it is characterized by the accumulation of fat in the hepatocytes. Okay, and the pathogenesis of fatty liver is not completely understood, but it is related to the amount of alcohol consumed, dietary fat content, body fat content, and hormonal status, and also other factors as well. And there are evidence that ingestion of large amounts of alcohol can cause fatty liver changes even if you have adequate diet. So the fatty changes that occur with ingestion of alcohol usually do not produce symptoms, and it is reversible with discontinuation of alcohol. So the symptoms are usually common symptoms like fatigue, feeling poor appetite, and then discomfort at the right upper quadrant, and also hepatomegaly. So other conditions, other critical conditions that could happen resulted from this hepatic steatosis, like increase in the mobilization of fatty acids from adipose tissue, increase in the hepatic synthesis of fatty acids, decrease in fatty acids oxidation, increase in the triglyceride production, and trapping of triglyceride in the liver. Next is alcoholic hepatitis. So it is an intermediate stage between fatty changes to the fatty liver and also cirrhosis. So it is often seen after an abrupt increase in the alcohol intake, and it is characterized by inflammation and necrosis of the liver cells. So at this stage, it is usually characterized by feeling tenderness at the at the location of your liver, feeling pain, anorexia, loss of body weight, unintentional body weight, nausea, fever, jaundice, ascites, and liver failure. But some individuals may be asymptomatic. So the condition is always serious and sometimes would bring to fatal. So in persons who survive and continue to drink, the acute phase often is followed by persistent alcoholic hepatitis with progression to cirrhosis within 1 to 2 years. So some might develop jaundice, coagulopathy, ascites, or NCAF. But if the patient discontinue alcohol, the hepatitis may resolve, but condition could often progress to stage 3. So the last stage is the alcoholic cirrhosis. So the symptoms are mimic to alcoholic hepatitis. So cirrhosis is actually a scarring or fibrosis of the liver, meaning that the structure of the liver cells are greatly affected. Okay, and at this point, it can develop further severe complications like GI bleeding, hepatic NCAF, or portal hypertension. So what is portal hypertension? It is an elevated blood pressure in the portal venous system caused by obstruction of blood flow through the liver. Okay, so ascites also could happen, which is an accumulation of fluid, protein containing fluid, which we call ascitic, within the peritoneal cavity due to increased pressure from portal hypertension and also decreased production of albumin. So a liver biopsy might reveal the presence of this cirrhosis, and the prognosis of the patient with alcoholic cirrhosis is depending on the alcohol abstinence and the degree of complications that the patient already developed. Okay, and then end-stage alcoholic liver disease. They develop all 3 clinical conditions. So the other characteristics like malnutrition, portal hypertension with varices, ascites, hepatic NCAF, hyponatremia, glucose alterations, fat absorptions, osteopenia, and also thrombocytopenia with anemia. So the malnutrition is one of the common and the one that we want to avoid, and the one we as a dietitian need to take an action. Okay, we need to ensure that the patient, walaupun the liver has been in damage, but we need to ensure that the other functions, the remaining functions of the liver still can be used, and therefore the nutritional status will be preserved. Okay, so malnutrition still could happen, okay, among the alcoholic liver disease, like for example overweight, okay, due to increased calorie intake from the alcohol addiction, okay, because of alcohol itself carries about 7 calories, if I'm mistaken, and per meal, okay, and then they could experience impaired digestion and absorption due to pancreatic insufficiency, morphologic and functional alterations of the intestinal mucosa due to excessive intake of the alcohol, and then compromised use of lipid and carbohydrate, okay, because of the impaired oxidation of TG, result in fat deposition and increased TG level, and that person also could experience insulin resistance. Okay, and lastly is vitamin and mineral deficiencies, which could result either from reduced intake, okay, alterations in absorption, storage, and ability to convert the nutrients to active forms. Okay, next we'll be talking about liver disease. So tadi kita dah cover on hepatitis, we dah cover on the alcoholic liver disease. Now it is a common liver disease. Okay, so it is divided into 3 types, which is fulminant, acute, and also chronic. So cirrhosis actually represent the end stage of chronic liver disease, in which the normal architecture of the liver is replaced by fibrous septa, which involve regenerative nodules of hepatic tissue. So this cirrhosis usually associated with alcoholism, viral hepatitis, toxic reactions to drugs and chemicals, biliary obstructions, metabolic disorders, which cause the deposition of minerals in the liver. For example, Wilson disease due to copper deposition, and also hemochromatosis due to iron deposition. So this is how it looks like. So this is a normal liver. and this one liver with viral hepatic damage. As you can see, there is a enlargement of the liver, and this one is the cirrhotic liver. Okay, so the manifestations of cirrhosis arrival ranging from asymptomatic hepatomegaly to hepatic failure. So often there are no symptoms until the disease is far advanced. So the most common signs and symptoms of cirrhosis, like for example, weight loss, but somehow it is masked up by the presence of ascites, which is the fluid accumulations in the peritoneal cavity, which you can see that patients with end-stage liver disease, they will have a protruded abdomen. Okay, so you akan kata, okay, bila timbang berat dia masih lagi mungkin overweight, mungkin normal BMI, but somehow when you do direct physical examinations, that you can see clearly that there will be loss of muscle mass. Okay, and then feeling weakness, anorexia, diarrhea, which frequently is present, but somehow ada juga patient might experience constipation, hepatomegaly, splenomegaly. These two you mungkin tak nampak, especially kalau dia ada masalah dengan ascites. Okay, and then bleeding caused by decreased protein factors, jaundice, skin discoloration, and also yellowish color on the sclera. Okay, abdominal pain because of the liver enlargement, and the late manifestations of cirrhosis are related to portal hypertension and liver failure. So this is the etiology and complications of cirrhosis. So there are many factors that could result to chronic injury to the hepatocytes, and therefore fibrosis and scarring of the hepatocyte cells, and lastly could result to cirrhosis. So the complications of cirrhosis, as you can see here, ascites, peritonitis, gastroesophageal varices, hepatic NCAF, hepatorenal syndrome, hepatopulmonary syndrome, and lastly carcinoma of the hepatocellular. Okay, and this is the physical appearance of a cirrhotic patients. Okay, icteric sclerae, iaitu dia punya ada color kuning pada mata putih dia, and then spider angioma, which is due to swollen blood vessels, so you can see it clearly beneath the skin surface. So dia akan ada macam like central red spot and reddish extensions which radiate outwards like a spider webs. Okay, and then alopecia, like hair loss, takut medusa, which is the appearance of distended and engorged superficial epigastric veins. So you can see radiating from the umbilicus across the abdomen. Okay, and what else? Ascites, enlargement of the abdominal, which is the peritoneal cavity actually, alright, and then altered hair distribution, testicular atrophy, and also edema. So there is a score on how to assess the prognosis of chronic liver disease and also cirrhosis, which is called Child Peer Score. Okay, so it consists of 5 main clinical features that is commonly seen among end-stage liver disease, which are encephalopathy, ascites, level of bilirubin, albumin, and also prothrombin time. So what is a prothrombin time? Do you remember? Ingat tak lagi? What is a prothrombin time? Anyone?
Masa untuk ni ke? Darah.
Hello? Anyone there? Saya bercakap seorang-seorang je ni.
Tak ingat betul.
Prothrombin time. Tak ingat? Ada siapa yang ingat? Apa pentingnya? Prothrombin involving blood clotting. Yes, blood clotting. So
Betul lah. Pembekuan darah.
is a test to measure how quickly your blood clots. Okay, so as I mentioned earlier, there will be a decrease in the prothrombin time, so therefore they are more prone to be having problems in the blood clotting. Okay, so as you can see in the table, so there is a few classes, class A, B, and C. So on how to obtain, on how to classify the patient at which classes are, is by adding score for each of the parameter. So the higher the score, meaning that the more severe of liver disease the patient has. Okay, next will be the complications of the ESLD, the causes and nutrition treatment. So portal hypertension. Portal hypertension is an elevated blood pressure in the portal venous system, which caused by the obstruction of the blood flow into the liver. So there will be an increased collateral blood flow and result in a swollen veins, or what we see as varices in the GIT. So the complications of this portal hypertension arise from the increased pressure and dilation of the venous channels behind the obstructions. And major complications of this increased pressure and the opening of the collateral channels are ascites, splenomegaly, and also formation of proto-systemic shunts, which can be seen in esophageal varices and rectal varices and also caput medusa. So these are the complications of portal hypertension. Again, and it is you can see from the increased pressure in the peritoneal capillaries, proto-systemic shunting of blood, which could result to hepatic encaph due to development, accumulation of ammonia and toxins in the liver, in the blood, and the last one is splenomegaly. So the complications of the portal hypertension, first one is the esophageal varices, which develop when the normal blood flow to the liver is blocked by a clot or scar tissue in the liver. And then the management for this esophageal varices is they will do endoscopic tube, which is used to tamponade the bleeding vessels, and then a repeated therapy of this can cause esophageal strictures and also dysphagia to the patients. So at this point of acute bleeding episodes, the patient cannot be fed enterally, so he or she may require TPN if he or she unable to eat, having a difficulty to swallow. Okay. And next is ascites. Ascites is the accumulation of fluid in the abdominal cavity, which is caused by portal hypertension, hypoalbuminemia, lymphatic obstruction, renal retention of sodium and fluid. And there are few treatments, medical treatments to treat this ascites, which is through paracentesis or the removal of the fluid by injecting a needle, okay, and there is a tube so that the fluid in the abdominal cavity will be removed out from the body. And also from this paracentesis also, the sample of the fluid can be further go for diagnosis, or also diagnosis for any diseases or even for the cancer. Okay. And also diuretics use. So you should monitor on the weight, abdominal girth, so that you can see if there is any episodes of ascites. Okay. And then urinary sodium concentration, serum levels of sodium, creatinine, albumin, uric acid, and electrolytes. So our part as a dietitian, so we need to restrict the sodium intake to no more than 2 grams. Okay, and for a severe restrictions of sodium, the diet may be unpalatable. So maybe you can provide diet like for example ONS, oral nutrient formula milk. Okay, and adequate protein is advisable if the patient have been on frequent paracentesis. And this is how end-stage liver disease patient looks like. As you can see here, there is a prominent bone can be seen, okay, from the ribs, from the shoulders, okay, and also presence of ascites. So somehow kalau you tengok closely, you akan nampak memang ada loss of muscle mass. But kalau untuk patient yang belum lagi nampak a prominent loss of muscle mass, so whenever you do a weight measurement, you can see berat dia could be in normal BMI ataupun overweight, okay, because of the ascites. So for the management of hyponatremia, so hyponatremia is common, okay, among ESLD, okay. So it occurs actually because of the decreased ability to excrete water because of the persistent release of antidiuretic hormone, and also sodium loss by the paracentesis, excessive use of diuretic, and also when the patient is on sodium restriction diet. So the fluid intake should be restricted to within between 1 to 1.5 liter per day, and then the diet should be on moderate sodium intake, okay. And next is hepatic NCAF. So hepatic NCAF is a syndrome observed in patients with cirrhosis. So it is defined by a spectrum of neuropsychiatric abnormalities in patients with liver dysfunction after exclusion of brain disease. So meaning that dia tak ada, kita kena ambil kira adakah dia ada masalah with brain disease which cause neuropsychiatric abnormalities, or is actually because of the liver dysfunction. So it is characterized by personality changes, intellectual impairment, and a depressed level of consciousness. So these are the major causes of NCAF, which are GI bleeding, fluid and electrolyte abnormalities, uremia, which is the increased level of urea in the blood, use of sedatives, hypo or hyperglycemia, alcohol withdrawal, constipation, and also acidosis. So this is the grading, okay, of mental status in hepatic NCAF using the West Haven criteria. So there are 4 grades, okay, actually 5 grades. So grade 0 is normal, okay. Kalau grade 1 and 2, normally you can see there is some sort of disturbance in the fine motor skills, and then in terms of the personality and memory as well, okay. So for grade 1 and 2, you might experience difficulty to obtain diet history because they have a problem with shortened attention span, memory, and then focus, and then they have a problem in the fine motor skills, and even have problem in speaking because of the slurred speech, and they need assistance for feeding. For the grade 3 and 4, which it is a severe form, okay, of problem in the mental status, so at this point they might require tube feeding. So these are the stages of hepatic NCAF. Okay, there are 4 stages. The first one, mild confusion with agitation, irritability, sleep disturbances, and then decrease in the attention. And then level 2, lethargy, disorientation, inappropriate behavior, drowsiness, and the last one, which is coma. So the management of hepatic NCAF is that the patients will be given neomycin or lactulose. So neomycin has been shown to be effective adjunctive therapy in hepatic coma by reduction of the ammonia forming bacteria in the intestinal tract. So it is a form of non-absorbable disaccharide, okay. Meanwhile, for the neomycin, it is a non-absorbable antibiotic which will decrease the colonic ammonia production. and therefore will decrease the level of ammonia in the blood. So the medical nutrition therapy for hepatitis and CAF, first, adequate protein is necessary because there will be high loss of protein, and then it should be supplemented with branch chain amino acids. Vegetable protein and caseins may improve the mental status. Casein-based diet low in amino acids, arachidonic amino acids, and also high in branch chain amino acids. So, high fiber content of vegetable protein diet may play a role in the excretion of nitrogenous compounds, which would be helpful to treat NCAF or to slow down the severity, the progression of the hepatitis NCAF. And then supplements with probiotic and symbiotics, which is a gut-friendly bacteria and fermented fibers. So these probiotics will be helpful to reduce the serum ammonia and also endotoxin levels. So according to this European Association for the Study of the Liver and the American Association for the Study of Liver Diseases, so they mentioned that it is classified as grade 1A, which daily energy intake should be given about 35 to 40 kilocal using the ideal body weight, and then daily protein intake should be given about 1.2 to 1.5 gram per kilogram per day, and the patient should be given small meals or liquid nutritional supplements evenly distributed throughout the day, and a late night snacking to avoid hypoglycemia. So oral BCAA supplementation is classified as grade 2B, but it is still recommended to be achieved and maintained in patients intolerant of the dietary protein. But however, the role of protein in the NCAF is controversial because the NCAF is actually caused by imbalance of aromatic AAA and branch chain amino acids. But however, protein restriction do not proven to improve the mental state. So it is advisable for the patients to be supplemented with BCAA and low in AAA. So if the patient is protein sensitive, it should be started with the low protein first, 0.5 to 0.7 grams protein, and increase the level up to the tolerance up to 1.5 gram per kilogram, especially for patients with protein calorie malnutrition. And then they should be given adequate calories to prevent catabolism of endogenous protein stores. Okay, and then many studies say that, for example here, Cordoba et al. Showed that restrictions of protein actually worsens the hepatitis and CAF due to the increased protein catabolism. So these randomized studies demonstrated that a protein intake of 0.5 led to increased muscle breakdown compared with an intake of 1.2 gram of protein per day. So it is recommended for patients with cirrhosis to consume 1.0 to 1.5 of protein per day to prevent muscle catabolism and to promote gluconeogenesis, which means that gluconeogenesis apa? The production of glucose from non-glucose products, which is coming from the protein in this case. Okay, so a temporary protein restrictions of 0.6 to 0.8 may still be appropriate in patients with acute exacerbations of NCAF until the cause is determined and eliminated. But there are consensus saying that low protein nutrition should be avoided for patients with hepatitis NCAF. So some degree of protein restriction may be inevitable in the first days of the treatment, but should not be prolonged. So oral BCAA and rich nutritional formulation may be used to treat hepatic N and generally will improve the nutrition status of patients with cirrhosis. And according to this study, saying that type of protein ingested may be important because patients with cirrhosis show variations in their toleration to dietary protein depending on its source. So this early many uncontrolled studies showed that dairy protein is better tolerated than protein from meat sources, and that vegetable protein is better tolerated than meat protein. But it is advisable to focus more on the vegetable protein diets because it contains more dietary fiber, and this fiber has prebiotic properties which results in decreased transit time, reduced intraluminal pH, and increase the fecal ammonia excretion. Glucose derangements. So glucose intolerance are more common to happen in nearly two-thirds of patients with cirrhosis, and about 10 to 37% of them develop diabetes. So it occurs because of the insulin resistance in the peripheral tissues. So hyperinsulinemia, which possibly because of the insulin production increase and the hepatic clearance are decreased. So fasting hypoglycemia also could happen due to decreased glycogen stores. So it is advisable for the patient to have small and frequent meals. So for the MNT of glucose derangement is that the patient need to be educated and to adopt MNT for diabetes mellitus. Okay. Can any of you explain to me what would be the MNT for diabetic mellitus? We have learned in part 4, right? What would be? Anyone? Apa goal? Okay, first, what would be the goals of MNT for diabetes?
Reduce carbohydrate.
Sorry, tak dengar.
Reduce carbohydrate.
To reduce?
Carbs.
Okay. Agama. Okay, lain? What would be the goal? We are talking about the goal of MNT for diabetes. You need to ensure that the goal is to attain and maintain blood glucose, blood pressure, and also lipid profiles as close to normal as possible, right? So the interventions, like for example, apa dia? Macam tadi you kata to control the carbohydrate intake. Okay, so how much you should give patient with diabetes? Berapa persen is berapa persen of carbohydrate from the energy intake is advisable? Hello. Ya, saya tak dengar. Are you all with me or not?
45%?
45% up to the range dia sampai
60.
60%. Okay. Okay, what else? Apa lagi? Low GI diet.
55% to 65%.
Okay. Okay, lagi. Low GI diet. Tadi ada seorang sudah tulis. What else?
Fluid intake?
Fluid. Okay, tapi it's not an important. Penting.
Reduce calorie diet.
To have a reduced calorie diet. Okay. Okay, right? Lagi?
Physical activity.
Berapa yang dicadangkan recommended?
150 minutes per week.
Okay, what else? Frequent meals to prevent sugar spike, including small snacks. So small and frequent meals. Okay. Lagi apa?
High dietary fiber.
High diet fiber. Why?
Mm,
Why fiber is important for diabetes patients? Apa yang dia boleh buat? Asyik suara yang sama je yang lain. Alright, slow down the absorption of glucose in the blood, and then it provides satiety. Okay, so dia akan prolong the GI transit time, right? Okay,
Help blood sugar control.
helps in blood sugar control. Okay, good. Okay, apa lagi? What else for MNT for diabetes? How about weight loss? Is it important?
Yes, for the overweight diabetic patient.
Normally, diabetic patients are overweight or obesity. So we encourage them to lose their weight about 5 to 10%, okay, over 3 to 6 months of period, okay. And then we need to educate them to consume sugar intake or sucrose intake of no more than 10% from the total daily energy intake. Is it? Betul tak?
Betul.
Right, dah lupa lah tu kan. Okay, next is steatoria. So the MNT for nutritional management for steatoria is to replace long chain triglyceride with MCT-oils in some nutrition supplements as oral. Okay. Alright, and then you may also try low-fat diet, but do not restrict unnecessarily. If the steatoria does not improve, so the restriction may be discontinued. Alright, so nutrition issues related to ESLD. So we know that malnutrition is the most common complications in patients with liver disease, regardless of the etiology. So the patients, the prevalence of malnutrition ranges from 25 to 80% depending on the severity of the illness. In patients with decompensated cirrhosis, malnutrition varies between 60 up to 100%, and only 20% of malnutrition can be seen with compensated cirrhosis. So decompensated cirrhosis meaning that a person having an acute deterioration in the liver function and present with cirrhosis, and it is also characterized by a presence of other clinical conditions like jaundice, ascites, hepatitis, hepatorenal syndrome, or variceal hemorrhage. Okay, that is decompensated liver disease. Right, for compensated cirrhosis, it is asymptomatic. So the liver still can do its function, okay, but because there is enough healthy hepatocyte cells to make up for the damaged cells and also the scar tissue caused by the cirrhosis. So at this stage, the patient who has compensated cirrhosis may stay longer for many years. So why do liver patients are at risk to develop malnutrition? Okay, it is caused by the causes of malnutrition in chronic liver disease is actually multifactorial. Okay, but it is divided into four main causes. Okay, the first one is inadequate dietary intake, impact in the digestion and absorption of nutrients, impaired nutrient storage, impaired nutrient synthesis and altered nutrient demands, and abnormal nutrient doses. Alright, so for the inadequate dietary intake, all forms of acute or chronic liver problems may be accompanied by loss of appetite, and the presence of ascites actually can add striking early satiety. So low sodium diets can be very unpalatable, and sometimes food intakes poor due to esophagitis, gastritis or pancreatitis. Second one is due to impaired digestion and absorption of nutrients. So degree of maldigestion is common in cirrhosis, resulted from a decrease of the bile salt solubilizations and severe maldigestion, okay, which common in ALD with pancreatic damage. So malabsorption with or without maldigestion occurs in alcoholics due to the toxic effects of alcohol on the small intestinal ultrastructure and the brush border enzymes. So many ALD patients experience rapid intestinal transit, increased mucosal permeability, impaired salt and water absorption. And absorptive problems are also seen in portal hypertension from any cause due to congestion of the intestinal mucosa. So the third factors which is impaired nutrient storage. So we know that liver is the main storage for many nutrients, particularly water-soluble vitamins. So loss of storage capacity because of the structure of the hepatocyte cells, okay, due to the cirrhosis, can therefore exacerbate the micronutrient deficiencies caused by either low or unbalanced dietary intakes. For example, thiamine deficiency. So although in this case there is actually a combination of poor storage, inadequate dietary intake, poor jejunal absorption, and even alcohol will promote the loss of thiamine in the urine. Fourth is the impaired nutrient synthesis and altered nutrient demands. So liver cirrhosis particularly will affect the protein metabolism with a reduction in the synthesis of transport proteins such as albumin. So this is caused by a combination of decreased functional liver mass and alterations in the amino acid demands. On top of that, reduced glycogen storage also increase the needs for amino acids for gluconeogenesis, while ongoing inflammation alters the pattern of amino acid requirements and therefore will precipitate the storage of the AA and cause AA shortage. So this problem is then made worse by a reduced capacity for transamination reactions, which should allow the liver to generate AAs in short supplies from those available. The last one is the abnormal nutrient losses. So cirrhotic patient may lose both macro and micronutrients from diarrhea, GI blood loss, renal losses of the electrolytes, which are also higher due to secondary hyperaldosteronism, and sometimes is exacerbated by diuretic use. So renal losses of micronutrients such as thiamine are also increased, and paracentesis, which is the medical procedure, okay, will lead to large electrolyte and protein losses. Alright. So in a nutshell, we can say that malnutrition in end-stage liver disease actually could increase the morbidity, poor wound healing, increase the infections, increase the complications, and therefore will increase their mortality rate, increase the number of treatments needed, increase the length of stay in the hospital, and lastly would increase the cost and make them to have a poor quality of life. Alright, so that's all for today's lecture. So the rest of the lecture we shall continue next week. Okay. Alright, any questions so far?
So far no, Doctor.
Alright. So notes I will upload after we finish this chapter next week. Okay. Alright. So that's all for today. Thank you so much, everyone.
Thank you, Doctor.
Thank you, Doc.
Thank you, Doctor.
Thank you, Doctor. Dah, Iza. Tutup.
Ya Allah.